Okay, resume recording. Thanks, Venice. Okay, so I basically going to get through these two learning outcomes this morning. Basically to get through some of the pharmacological stuff that we got through during the e-learn. You already heard about it. So the main thing I want to concentrate on for this particular IC is how to apply what you've heard theoretically, right, from the e-learn. And then, of course, to apply some of the guidelines and learning from essentially what we want to take away from today, okay? So essentially, right, at this time, I want to ask anybody who has thought about it or maybe wondering about it, what's the difference between dyslipidemia and hyperlipidemia? Does anyone know? Or anyone wants to hazard a guess? Anyone want to give it a shot? Let's see how you can warm up this morning. All still tired and haven't waken up yet. Anyone?
Hi, Prof.
Hi.
Is dyslipidemia means like dysregulation of the levels of lipid, right? The triglycerides, right? Then hyperlipidemia means abnormally high levels of triglycerides, is it?
You are on the right track. Yes, so good guess. Dyslipidemia can actually refer to any sort of dysregulation of lipids. It can also even refer to people with very low LDLs. I think you would have gone through the session with Dr. Mitchell yesterday, right? And he took you through the different types of the dyslipidemia type of profiles. Okay, I'm not an expert in that. He's more of an expert than I am. But there can actually be people who present very high triglycerides and very low LDL as well. So the whole spectrum of things is called dyslipidemia. And that's why you would see in literature that is used interchangeably. In the past, we used to call hyperlipidemia quite a lot. It's just that now you see a lot more literature referring it to the whole concept as dyslipidemia instead. So for the purpose of the lecture, I will be going through them quite loosely as well. So don't get confused as to why I say sometimes hyperlipidemia and sometimes dyslipidemia. Yep. Thanks, Guang Yao. That was a good shot. Okay, so as the rest are slowly streaming in, let's start off with the Kahoot as usual. So let's go to our Kahoot screen and I shall start the music while you guys start to log in, okay? As usual, log in with your names and the pin over here. Let's get ready to warm up those muscles in the brain. Wow, Junzong, this time full name, huh? And Suhyun also, wow, big letters. All right, everybody come in. Let's do our usual Kahoot games. Okay, who's Sushi? Not first place, You guys are really good at these things. A Pixabay, really? And that, okay, Papa Clown. Funny guys. I lost. Okay, don't be lost. You will be found by the end of today's lecture. Oh, DTSY again. And Rivoxaban, really? Okay. Okay, 44 of you in. I've got 58 of you in the Zoom meeting. Any one of you coming in? Otherwise, I will just press on ahead. The Kahoot link is over there, and the game pin is as seen 7542355. Okay, let's not wait for the rest. We'll start with 48 of you. Let's go. All right, welcome to the Kahoot for IC16. Dyslipidemia. Are you ready? Okay, first question. It's a multi-select question. Which of the following are characteristics of statins? Jeng, jeng, jeng. Come on. Let's see. Aha. So, some of you chose, red as well. Okay, so a number of you chose should be those ON. A couple of you chose so the correct answers were supposed to be that if you double the dose of a statin, you will reduce LDL by additional 6 to 7%. Remember, that's a guide. It's not biblical truth. And your patients don't read textbooks, right? So there will be people who will respond slightly differently, but it's just as a general rule. Statins are first line for LDL lowering. You're correct. Okay, very good. Very few chose the yellow one. Remember the potency of statins. I shall not give you the answer now because it's another question behind. And okay, so most of the statins should be dose ON. Yes, that's the default. But remember that when people have got compliance problems with atorvastatin and rosuvastatin because they've got a longer half-life, you can actually give them in the morning, right? So by default, you're correct, should be dosed ON. Remember, when you see an MCQ like this with such an absolute answer, right, most of the time it's false one. Okay, so that's a tip for you when you see MCQ questions. Essentially, there are even studies that show that you can do alternate day rosuvastatin for people who have got muscle related issues as well. Okay, let's see who is top on that list. It looks like it's Junzong. Congratulations, Junzong. Next question. Question 2. Also multi-select. When someone has muscle aches with statins, what would you do? Okay, majority of you got the answer correct. Some of you said myoglobin. Actually, that was a trick question. We should test for CK or creatinine kinase, not myoglobin, okay? TLC, yeah, okay, so the particular question on shoulder aches, right? That's not the usual presentation of where muscle-related side effects are with statins, right? Do you guys recall where it's going to be? Generally, it's in the large muscles that are proximal. So most of the time, you see it presenting in people's thighs or in the upper arms, okay? So generally, you won't just get shoulder aches. I also have permanent shoulder aches. Doesn't mean I'm on statin also. So remember what the red brown urine means, right? That is potentially myoglobinuria. That is a life-threatening sign and symptom. And if anyone has that, you better make sure you send them to any right way. All right, so CK is correct. Good job, guys. Let's see who's top now. It looks like it's still Junzong. Congratulations. Okay, question 3. Another multi-select question. What about ezetimibe? Quickly, 10 seconds left. Hurry. Fastest finger wins. Okay, correct answers are correct. Quite a few people got tricked by the LDL comment. So it's actually blocking the absorption of cholesterol, not LDL from the diet. LDL is actually produced by the body. Remember the lipid cycle? All right, trick question here. Good job, those who got it correct. And let's see who's top. Oh, still Junzong. Junzong, you are power man today. Okay, next question. High intensity statins lower LDL by... This is testing your memory, but this is important, so you all need to know this very, very well. Only one answer. Come on. Yes, 50%. Oh, some say 30 to 49. This is high intensity statins. The ones who are moderate intensity is the green range, okay? The yellow range is correct answer. Why so few people answered the yellow? Okay, next question. Let's see who's top. Still Junzong. See who can topple him by the end of this session. Okay, next question on fibrates, multi-select question. What about fibrates? Okay, correct answers are actually yellow and green. Oh, so few got the green answer. So many of you did blue. Oh, you got tricked because the after food one is for phenofibrate. For fibrosol is supposed to be taken before meals. Okay, that was a trick question. And then for green, to be considered to treat TG more than 2.3 from optimal statin. Well, that is supposed to be the truth for some guidelines, and that's something that we're going to take through this particular session today. All right, let's see who's on the top still. Is it still Junzong? It's YD. Who is YD? We'll find out. So congratulations, YD. You managed to topple Junzong. Let's see by the end of the lecture today who's going to be top. Okay, So now that you guys are warmed up with your finger muscles, let's see how you can warm up with respect to your application today. Okay, so we are just going to focus on when and how to treat hyperlipidemia, and then maybe managing a couple of scenarios where it's interesting with respect to the use of statins as well as fibrates. Okay, so this is the main reason why we treat cholesterol or LDL, high LDL levels, right? Because these LDL are very troublesome particles and they happily get themselves ingrained into your arteriolar cells here in the smooth muscles. And as a result, right, the macrophages just go and chomp them up, and macrophages actually form these foam cells over here. And these foam cells are the ones that cause a lot of trouble because that's what attracts a lot of the white blood cells and all that. And when there becomes an inflammatory nidus means it's a seed, right? So when there's an inflammatory nidus, that's when you start to create even more inflammation. And as a result, once some trigger happens and there's a rupture of this particular plaque, that's when you get a massive heart attack. Okay, that's what generally happens, whether it's be in the heart, which you get acute coronary syndromes from, or you get a cerebral vascular accident, which is a stroke or transient ischemic attack. It's the same thing that happens in the vessels of the brain. Particularly for carotid artery disease, most of them are a bit more stable. And thankfully, you don't get like a stroke from these carotids, but usually it's just the narrowing, which you can see looks like this gunk in a pipe of a like maybe clearance pipe, right? You get all these things that's all accumulated. And when generally you get this particular problem of atherosclerosis inside your cardiac vessels, right? That's when you get this angina. And angina is usually what we call stable angina, right? Is when at baseline, when you don't exert yourself, you don't get such problems. But when you exert yourself, you actually get into more problems. Because of this narrowing, there isn't enough blood that can actually supply your cardiac muscles. That's how you get these angina symptoms, okay? That will be what you'll be dealing with Dr. Wee Xue Ting tomorrow. I will just keep to my schedule today with respect to lipids. Okay, so this is how the lipids cause trouble. The worst feared scenarios are usually the acute coronary syndromes and cerebral vascular accidents, because if they happen at places which are very critical to you, like when you talk about the cardiac vessels, right? If it happens at the very start of where the vessels split for the left anterior descending artery as well as the left circumflex artery, right? Once it blocks there, it actually knocks out two pathways of your heart. So it can actually become very damaging for a patient. And that's why we want to prevent too high levels of LDL. And essentially, that's why we're even discussing treating LDL to start with, okay? So what is the Asian or Singapore data that's involving LDL? Now, we know that in East Asia actually covers places like Korea as well as Japan. So not so much Southeast Asia, but we're talking about just in general Asia. Compared to Asian countries, there's actually lower cardiovascular heart disease mortality, right? However, right, the age standardized mortality rates in Southeast Asia are comparable or higher than the Western countries. So it's a very interesting trend that has been observed. Now, because of rapid aging and increasingly sedentary Singapore, a lot of us sit in front of computers, especially now work from home, right? Everything is in front of computers and Zoom, right? In the past, we used to be walking around, getting from meetings to meetings, but we're getting increasingly sedentary. And because of this, obesity becomes more and more common. And therefore, because of the more increased prevalence of obesity, there's also a parallel increase in type 2 DM. And a lot of times when you see a diabetic patient, right, they commonly also have hyperlipidemia as well as hypertension. Okay. Now, ethnic Malays and Indians seem to have a larger proportion of these diseases compared with the Chinese, which is a very interesting trend. So there could be some suggestions there's some ethnic predisposition with respect to disease. Not that I'm being racist over here, but that's what's been noticed in Singapore, right? So the increase of 1 millimole per liter of cholesterol, and this is total cholesterol we're talking about, is equated to about 35% increase in risk of coronary deaths. In Singapore and in Asia, what is thought to be more damaging and more impactful is really strokes. It seems like strokes is a bigger problem with Asians than cardiovascular diseases, particularly heart attacks. However, whatever it is, we just need to make sure that we reduce our cholesterol well. And this particular increase in cholesterol seems to be shown with association with fatal and non-fatal stroke. But well, it's not yet with stroke mortality. So I don't know whether you think it's a good news or not, because people get stroke, they don't die. But then if it's going to be quite damaging to their lifestyles, right, they can't work anyway. And then, you've seen shows of people who have got a stroke and they're hemiplegic and they can't do their usual activity. That's actually very damaging towards their QOL as well. Okay. So there's some change, there's some differences between Asians and Caucasians, and I think that's the main thing that I wanted you guys to know. Essentially, for the Caucasians, right, the risk of death seems to be lower with respect to mortality rates. That's cardiovascular disease in general. So it becomes particularly important, even though we don't seem to have as much cardiovascular deaths in East Asia. It seems like Southeast Asia is an important thing, and we do need to manage our patients with high cholesterol better than what we're doing. So how common is this hyperlipidemia problem in Singapore? This is a chart that's familiar to you guys, right? So you can see that actually hyperlipidemia, the prevalence is actually rising from year on year. We don't have much more in updated information. I think mainly because of COVID, I've contacted this the National Registry of Diseases recently, and they're a bit behind on the reporting. In fact, the 2019 data is not even out yet, so I wasn't able to show you guys, but suffice to say, the incidence of cholesterol problems are rising in Singapore as well. And I am not surprised, because locally we see the presentations of myocardial infarction or heart attacks, right, of our patients in Singapore, right? They're generally younger by about 5 years on average compared to the Caucasian countries. Our MI patients, especially in NUH, right, they average around 55 years old. In KDPH, where I was from, the average age of an MI patient is about 60, 62 years old, and that's actually substantially younger than the European countries, where the MIs present at 65 and sometimes even 70 years old for the first time. So clearly something is quite wrong with the picture over here, and we really need to be doing better with respect to treatment of our primary prevention of our patients in Singapore. So here is where the confusing part is going to start. So don't worry too much if you cannot quite grasp this. In the next couple of slides, what I want to show you is the differences between the various guidelines. Okay, so I'll start off with the MOH one first, which is 2016. And clearly, if with the 2017 hypertension guidelines, we can really say they are quite dated in the recommendations, much worse with 2016. So just to give you a sense of comparison between Singapore, America, and Europe. Okay, so the American guidelines is what you're familiar with as well, with the hypertension guidelines we talked about, the American College of Cardiology. And then with the European guidelines, it's a collaboration between the EAS, which is the Atherosclerotic Society, and also the European Society of Cardiology, where these particular statements and guidelines were being written. And actually, the more contemporary one will probably be the European one, because they are more recent, and they probably would have captured a lot more data in their recommendations here. Okay, so before you start to faint about how busy this slide is, don't worry, let me take you through, okay? So first, there are a few parts that are similar, right? If you can see, there's a very high risk, and on the other side for the European, also high risk, but then for the European one, there's also a very high risk. Now, I'm going to start to show you the difference between the groups. So if you look at how Singapore one is, right, the diabetes with chronic kidney disease, as well as familial hypercholesterolemia, which you all covered yesterday with Dr. Mitchell Lai, right? Or just FH for short, easier to say. They belong to the very high risk population. Okay, now for the American one, that's similar, thankfully, but they classify them under high risk conditions. And CKD is also as a separate component here in the American guidelines. And then for the European guidelines, it mentions diabetes without any target organ damage. And for people who have a long-standing diabetes of more than 10 years with an additional risk factor, right, those are considered high-risk patients. Okay, so they're somewhat similar in that sense in terms of recommendation. And then, so when we talk about CKD, they split it to moderate and then severe CKD. So moderate CKD, when we're talking about eGFR between 30 to 659. Now, don't worry too much about that, because that's going to be in the second semester. I just wanted to point out the differences in the various guidelines. The fact that the moderate CKD belongs to high risk. And if you look up there in the very high risk, the severe CKD is up here. Okay, so the very high risk, they also have this extra, almost like a microscope, right, on people with diabetes as well as CKD. And when you have added complications, right, you're considered very high risk. Okay. For FH, the American guidelines also put them under high-risk conditions. And here you see very high risk under the European one. I have a reason, and I think that the reason for European concern is because FH is fairly common in the European population, or because they have a lot of work done with FH. And if you are curiously interested in this thing, right, the whole FH criteria actually originated with the Dutch, right? So you can tell that FH is probably a bigger problem in Europe than anywhere else in the world. And therefore, they are fixating quite a bit, and they classify FH with ASCVD or another major risk factor. You don't even have to have an ASCVD, right? As long as you have FH and another risk factor, right? You are considered very high risk already. So they're pretty aggressive in treating FH patients in Europe. Okay, so for the very low risk people, right? You remember Mr. Gao, right? Mr. Gao Shuyara. So essentially, those people with a very low 10-year risk, right? Then they belong in the very low risk population. You usually want to estimate them. That's when you don't have an equivalent like ASCVD or all these other conditions that are of note, like FH, diabetes mellitus, CKD, or ASCVD. Okay, so for people without these compelling reasons, then they become a low-risk type of patient population. That's when you start to use scores like the ASCVD scores. In Singapore, they have a table that you'll practice later on for fun. Okay. In Europe, they use the score. Remember, we were talking about the score, and this was also talked about during the hypertension series of lectures. Okay, here. And the score is very much validated for European patients. So if you try to look for Asian population, right, you probably can't really find the correct ethnic group to be using the score with. So I probably wouldn't bother with the score risk score. I probably would pay a bit more attention to the Singapore one for this purpose, mainly because the American one is also not quite validated for Asians as well. Okay, this is again just pure knowledge for you. You don't really need to know this or memorize this for the exam, but just to let you know that there are different types of risk scores that you will see in literature in the future when you ever do a journal club or when you ever have to go to work and people talk about all these things, right? Then this is what you know and connect with in the real life. Okay. So what is this whole concept? Why am I talking about risk strata? Okay, so the key concept behind this whole idea, right, is that the risk strata will determine your LDL target or statin dose intensity. Okay, so on the reverse this time around, I'm going to cover people with ASCVD first because that's the easiest people to get out of the way. Okay, so the group that has got ASCVD, for example, someone with a heart attack before or angina, or some sort of ischemic heart disease that's proven, like you've sent them for an angiogram and you've seen some atherosclerosis, right? And you know those are considered like ASCVD equivalents. Then those are secondary prevention. And the people who are primary prevention refer to Mr. Gao, like Mr. Gao, who had this no other risk factors, but just very unhealthy lifestyle. Okay, then we'll talk about them at the end. So what does this mean? So don't have to memorize whatever I've covered earlier with the guidelines. That was just to give you a sense of how confusing it can be in the real world. Now, I've tabulated this nicely for you. Thank God for Prof. Doreen Tan, right, who's helping you with this kind of things. So just to highlight this particular table, if you don't remember anything else, please remember this particular table, okay? So the people who are very high risk or considered very high risk ASCVD, if you recall, somebody who has a heart attack plus poorly controlled diabetes, for example, or maybe they have additional peripheral vascular disease. Those are considered very high risk ASCVD patients. With respect to the Singapore guidelines, I probably will not even bother about them anymore. Pay attention to what the ACC as well as the ESC tell you. Okay, so I would say that I will follow the ACC guidelines at this time. Okay, if people who are still above 1.8 millimoles per liter, right, for LDL, you would think about adding ezetimibe on top of the statin. So for people with very high risk CVD, you don't even need to think, right? You start with high intensity or maximal dose of statin. Okay, I'll explain why ESC talked about 1.4 later on, right? Just bear with me as I talk about the idea behind high intensity and LDL target of 1.8 first. So you can do your math. You know that high intensity reduces LDL by about 50%, right? So you can even do your math and you see if people who have got familial hypercholesterolemia, right, they usually present with LDLs very high, maybe 4.7 or even 4.9 or even 5, above 5. If you reduce that by 50%, right, you will not be even anywhere near 1.8. So if you don't use ezetimibe, right, it's almost impossible to get someone with FH all the way down to 1.8, okay? Let alone someone with 1.4 as a target, which is the European guideline. Now, let me tell you why the European guideline now tells you to target for 1.4. That's because they're very, very aggressive about the use of PCSK9 in Europe. Okay, and the guideline makers, especially the EAS, right, are huge proponents of the use of PCSK9, especially in the FH population. And we'll talk about this population much later on. Okay, but don't worry too much about FH, okay, because there's not that frequent in Singapore. It's just that if you ever see it, you need to think about the fact that it could be one of your modifying risk factors when you think about LDL targets. Okay, so in all intents and purposes, as long as someone has got ASCVD, okay, they're already considered very high risk, right? So you have a heart attack, right? Then you will have targeted for LDL of less than 1.8 millimoles per liter. Okay, jing, 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 please remember that. Okay, so the people who are supposed to be high risk, right? But okay, by ACC's description, not at very high risk. It doesn't mean that these people are at low risk, no. ACC is just referring to them at not at very high risk, because if you're not at very high risk, right, you're already low risk. So they are considering this group as the intermediate, almost, that's not as very high risk group, okay? And again, ignore Singapore guidelines, because I probably wouldn't pay attention to Singapore guidelines anymore. Follow the American and the European guidelines, okay? So if someone has got ASCVD plus means someone has got ASCVD, or high ASCVD risk score means don't have ASCVD, but score high on the ASCVD risk score, right? Then you need to reduce LDL by at least 50%. So what is it saying? It's saying the same thing as the very high risk population. So actually you don't need to memorize. Just make sure that high risk, you just reduce to less than 1.8. Okay. And whereas on the ESC side of the house, right, they recommend 1.8 as your target. All right. So again, don't need to remember 1.4, just remember 1.8 for now. Okay. If you ever need to get anyone to 1.4, right, then you just need to think about the fact that on top of statin plus ezetimibe, you add on PCSK9 inhibitors. Okay. Third group, intermediate group and low risk group. Okay. Again, don't bother about Singapore. Don't even think about it. For the other groups, right, we're talking about the intermediate and low risk groups with respect to just DM as a standalone. Okay. And you remember on the ESC side of the house, right, they talk about DM with risk factors of long-standing diabetes for more than 10 years, right? Then it becomes a high risk. So if you look at the high risk versus intermediate risk in the table over here, right, you can see that people with just newly diagnosed DM, right, they're happy to reduce people to a target of 2.6. Okay. Whereas if someone who has been long-standing diabetes, or maybe one risk factor, say maybe nephropathies or albuminuria, then you become a high-risk patient, then you reduce LDL to 1.8. Okay, so actually the LDL decision with respect to target LDLs, right, is a lot easier than the hypertension guidelines, okay, because it's a lot more straightforward. And therefore, I said we'll start off with people who have got compelling reasons for you to lower LDL first, before you go to that group that's low risk, which is going to be fairly more confusing for you. All right. So remember, in front, can you remember? The front is just to set up for your understanding of this particular table. So remember the concept, the risk stratification will help you to determine what your target LDL is. All right. So this is a table. This is a nice chart by the ESC. My only bugbear is really with the 1.4, mainly because I feel like it's going to be very untenable for Singapore to try and chase for the 1.4, because that means that a lot more people need to be on PCSK9 inhibitors. But all that being said, we have to admit, right, the fact that the lowering of LDL, even all the way until 0.25 thereabouts, even with PCSK9 inhibitors, right, you can actually see a parallel drop in the CV risk, just like this particular line. So if you plot all the way through as a graph, right, with respect to LDL treatment goals and CV risk, right, you can actually see still a linear drop, no? Even beyond 1.4 as a cutoff, right, you can still see the CV risk reducing further and further. So I started to think as though LDL lowering, right, is almost like a rich man can offer, they will live longer kind of a thinking, right? Because in order for you to get to below 1.4, you really do need to be thinking about using PCSK9 inhibitors, which cost you about $500 to $600 a month in the restructured hospitals. In the private care setting, it probably can maybe sometimes come up to almost $1,000 if you were to be on a PCSK9 inhibitor. Okay, so just remember this particular chart for the sake that you have a correlation between the LDL goals as well as the CV risk. That means the more you lower LDL, right, the more actually you reduce CV risk for any patient. So I feel like what's really standing in the way today for us in getting this thing right is really the lack of cost effectiveness with respect to the use of PCSK9 inhibitors. So the moment we get a more potent agent, right, like inclisiran, that's probably coming into the market by the end of the year, and inclisiran is hopefully more cost-effective than PCSK9 inhibitors. And I've been talking to the Novartis people who was actually, incidentally, the market manager was one of our previous pharmacists before. And I trained her personally as a pre-reg. And I told her, you know, if you can price inclisiran much lower than PCSK9 inhibitor with the same amount of LDL lowering, I think you will have a lot more of a market share. And I'm not saying this because I want to have a share with Novartis, but more because I feel like the curve over here really does make sense. Okay, so ASCVD is here at 1.4. So just don't get confused, all right? In all intents and purposes in Singapore, let's treat it as 1.8. Okay, so let's go to Mr. Kolupu. Those of you who are familiar with Tamil, Kolupu actually means fat. Okay, so I hope that you're not thinking that I'm making fun of your language or your patients, right? It's just to make the concepts actually stick with you. So Mr. Kolupu is a 57-year-old patient, and he's a prata shop owner. He's a smoker and a non-drinker. He's married with 3 children, and he's got a recent ST elevation myocardial infarction, or STEMI. Okay, 3 months ago, he was discharged with aspirin, ticagrelor, atorvastatin, bisoprolol, as well as metformin. Okay, so these are the common things that you see for someone with diabetes post-MI, as well as hyperlipidemia. So at least 5 to 6 medications once they have an MI. That's a very common thing. So his BP ranged 130 to 140 around there during admission, and his BMI is on the high side, 28.5 kilograms per meter square. Okay, so the baseline labs during this admission, right, was that his baseline LDL was 4.3 millimoles per liter. Okay, so remember that. His HbA1c was quite jalat, 19.9%. The rest of the other labs were unremarkable, meaning that they are nothing special. Okay, they are all within the normal range. And his ejection fraction on echocardiogram was 45%. And if you recall what this is have like a preserved ejection fraction. So it's not yet heart failure because he doesn't have congestive symptoms. Okay, so he's just an MI with reduced ejection fraction. Okay, so this is ASCVD, STEMI. And then the LDL reduction that is conferred upon by 80 mg of cholesterol lowering drug like atorvastatin, right? What is the percent LDL reduction? Who can tell me? Anyone? Quickly. How much is conferred by atorvastatin 80 milligram? Anyone? Hello, anyone there? 60%. Yeah, okay, about 50 to 60%. So you guys are right. Good job. So I would take it as about 66, maybe 50 to 60%. Yeah, so basically about there. So if you calculate from 4.3 dropping by at least 50%, right, he still cannot reach 1.8 quite comfortably, right? Okay, so this is the chart that you saw during the statin e-learn. And remember the relationship between the statins, and I'll tell you why. So you don't really need to remember the actual breakdown in the percentage lowering, because all you need to do is just have one reference source, okay? So what I generally remember, right, for me, because atorvastatin 40 milligrams is very commonly used in KDPH, so I only remember 40 milligrams of atorvastatin. If you look at the green bar over there, it reduces LDL by about 50%, okay? So you know that the increasing, decreasing also, doubling the dose, right, would have conferred an additional 6 to 7%, right? So because of the doubling of the potency, it's almost the same as halving or doubling the same drug. Okay, so you can work out your relative potencies from where one point is going to be. So no need to memorize, all right? Then the next thing you need to remember is ezetimibe, right, adds on another 20+% lowering to the statin. Okay, so how I remember this is because of the product Vytorin, right? Vytorin, the lowest combination is actually 10-10. Okay, so 10-10 actually is the same as actually giving simvastatin 80 milligrams. So if you look at this particular, okay, if you can see my mouse over here, this Vytorin 10-10 is the same as 80 milligrams, right? So it's almost like doubling it one time to 20, another time to 40, and the third time to 80, right? So that actually gives you about 18 to maybe 21% reduction. So that's how I remember the additional impact of ezetimibe. Okay, so those are a few reference points that you all might want to start to remember, because this is important as you want to titrate the statins for your patients. Okay, so for Mr. Kolupu, yes, his baseline 80 milligrams would probably drop his LDL by 60%. Okay, so this is an important chart. So earlier we had our Kahoot, right? And the people, some of you were quite mixed up with respect to the high intensity. Remember, high intensity statins refer to atorvastatin that's 40 milligrams or 20 milligrams of rosuvastatin. So remember, you see here, the impact is half, right? So remember the potencies, right? Because rosuvastatin is twice as potent as atorvastatin, correct? So that's why this dosage range is here. So again, just have one reference point. You don't need to memorize everything that's in this particular class, all right? Just one reference point, and you can work it out from there. Moderate intensity lowering, 30 to 49%. And then usually there's a low intensity lowering, but in ASCVD patients, you don't even need to go and think about low intensity anymore. You probably need to go with high intensities, particularly for people with an acute stroke before or a heart attack before. Okay, remember this slide. Okay, so what are the questions to ponder for Mr. Kolupu? Now is for your turn to answer questions, okay? Which risk group does Mr. Kolupu fall into? Anyone? You can either voice out or you can type in the chat. Either way is fine. Anyone wants to speak up? Also better. Okay, what's his risk group? He has a STEMI. Yep, so he's at least high risk, right, Jiahao? Very good. Okay, so he is a high risk or very high risk patient. What's his target LDL? Anyone? If he's a very high risk patient or high risk patient, what's his target LDL? This one must roll off the tip of your tongue. Nice, less than 1.8. Very good, Venice and Yashwini. So his target is less than 1.8. And I put in question mark there 1.4 because it depends on where you are at. If you're going to be in Europe, potentially you might want to think about reducing his LDL to less than 1.4. So how much LDL reduction will he require? If you recall, his baseline was 4.3, right? How much does he require by percentage? Someone do a quick calculation. About 58%. Thanks, Jeffrey. Yeah, so he requires between 58 to 68%, depending on whether you are doing LDL target as 1.8 or 1.4, right? So if you go by this particular equation, if you give him like atorvastatin at 80 milligrams, you can pray that he does get to goal by the time he comes back to appointment, right? So which agent should we start at this particular point? So if basically he comes back and his LDL is still on less than 1.8, right? Then what do you think you will start for him? Atorva 80, still not at goal of less than 1.8. Nice, Venice. Thanks, Andrea. Ezetimibe is the answer. So you would think about adding ezetimibe next, right? So, but essentially you want to give him the best shot first, and then you will let him have the atorvastatin, maybe 40 to 80 milligrams first, and then you will think about what you want to give him later on. In some settings like NUH, I know that they use quite a lot of rosuvastatin commonly, okay? So you may not only just see atorvastatin. Now, when to add on, you would think about adding on the ezetimibe at the coming appointment. And what are the counseling points? Come, this one you all must say out. If you type, be too slow already. What are the counseling points? Come, someone throw out a few points at me with respect
like
to the high dose. Yes, who is that?
The muscle ache thing, and then like
Okay.
observe any change in the urine color, so that he
Thanks.
can be aware.
Thanks, Andrea. You're talking about the muscle adverse effects, right?
Oh yeah.
Yeah. So Hyun, you have a thought? What else will you tell him?
I will tell him to I mean Andrea say the everything lah, but maybe tell about like things like diet control and stuff also. Because
Why?
also
Why? Because he's a prata shop owner, is it?
well, I mean he's also has a very so that the LDL level doesn't increase. I mean, like even though we take medications, I feel that we still I mean you go through in the e-learning that lifestyle modification are still important to give together with the medication. So it's by default, it's like hypertension or by default must give kind of thing.
Right. Good job. Thanks, Soo-hyun. Yeah, so Andrea is also right that you need to warn him about the muscular side effects. And also Soo-hyun is right that we need to watch about the modification of lifestyle. For him, I think it'll be a bit more beneficial if he can lose weight, right? Because remember, we're talking about how diet, oils and fried foods, right, impacts triglycerides a lot more than LDL, right? So it's important to tell him to lose weight as well, because that is likely to be what's the most effective for him to lower LDL by non-pharmacological means, right? Okay, anyone else has any thoughts? What else you want to tell him? Very important thing. Remember, I was sharing you the story about how my friend's mother, right, went to pharmacy to collect her statin for the first time. And then we download this whole list of adverse reaction. Then the mother go home, don't want to eat the statin already. So what do you guys think? What else you want to tell him?
Like, or maybe tell him about the importance of taking the medicine, even if like the side effects maybe like scary, because like some patients, even if we hide away the side effect from them, right, they can search up themselves. So like it's important to like counsel the patients on the importance of taking their medicines.
Right. Thanks, Andrea. That was a very good concept to stress. Okay. So Venice is saying also that the side effects are rare. Yes, it's true that it's rare, but you see, we always say what, no? If you think that the side effects are rare, right? To the patient, once they gonna that side effect, right? To them it's 100% because they are n equals to 1. So it's always important for us to take the perspectives. And that's why we have to be quite careful about how we say things. So Andrea is absolutely right? How would we make sure that this man, when we first talk to him, right, would we have gone with him to say, oh, you need to lose weight, or you need to watch for your urine, make sure there's no red-brown urine or red-brown coloration? What would we tell him first? What do you guys think? Anyone? How would you manage your prioritization of what you would tell him first? You. Anyone there? How about Oliver? Oliver, what do you think?
I'm not really sure. Because Jiahao right in the chat, she said, inform doctor if red flags appear. So
Okay, so that's the first thing you
yeah.
would tell him.
No, I think okay, if I read off the slide, like e-learning, so it's the first time taking the medicine. Then talk you through some precautions. So, but it may sound dangerous and scary, but there are other patients on this medicine also that didn't have this significant problem. So they are very important to pick up the red flag, as Jiahao mentioned in the chat. And seek medical help early. Yeah.
Yep. Thanks, Oliver. I think Genting is suggesting to talk about benefits of statin first. Yeah. So if you were a layperson, I mean, all of you are a layperson at this time somehow, right? Because you haven't quite been exposed to all these horrible healthcare things that we are trying to ingrain in you. So if someone told you, wow, this statin will cause this red urination or the stuff, you'll also be scared, right? So generally what I would probably do, right, is tell them what the benefits of the statins are first. Okay. So the counseling points, all of you are right. You probably want to talk about intended effects, the CV benefits, as well as the adverse effects. And then remember this particular slide that you have cited, Oliver, as well as Jiahao, right, from the e-learner. So the other things that we need to remember to tell them, right, is that statins are regarded to confirm mortality benefit, particularly for those with underlying ASCVD, those heart attack patients, right? So once you are a layperson and you understand that this is going to be the benefit for you, right? Then it becomes clearer, right? The fact that you don't want to have another heart attack again, or you don't have another stroke again, that will already be the impetus or the motivation for wanting to take the statin really, right? Then once you say, oh, this is so important because we know that it's got mortality benefit for heart attack patients. In fact, it can prevent a stroke again, can prevent a heart attack again. And the people who value these things, laypersons really value not having that disease again or dying, or maybe even permanent disability with an issue like that, particularly stroke, right? So I always tell my patients, oh, you've seen those movies about how patients who have stroke, they are not able to move well on their own. So when you tell them all these things, right, it gives them already the context for why they should be taking these medications, right? Then I'm not saying to scare them or anything like that, but give them the context. So it's important to know why they're on a statin with respect to the indications. And also related to this, right, it's so much more difficult to tell somebody we are trying to give statin for primary prevention because they haven't had a heart attack yet, right? So it's hard for them to even imagine that they would have a heart attack. Okay, so it's far easier if you have someone who have a heart attack before or a stroke before to say that, oh, the statins are so important because it can prevent a stroke again, right? Then you remember, if you basically say all that as a context, then it makes it easier for you to tell them about these other adverse effects, right? Because then there's a context that, oh, if I don't take this statin properly or my LDL doesn't get to the target levels that I want, then there's a risk of a heart attack again, or there's a risk of death. And of course, then it becomes even more in terms of perspective important because the incidence of, say, a muscular side effect like rhabdomyolysis is less than 1%. Oh, come on, how rare is this thing, right? So when you do this in context, right, then you basically are able to confer your messages even clearer to your patients. Okay, does that make sense? All right, so basically we will tell him about the intended effects, and for him, because he had a heart attack, we'll tell him statins will save your life. And additionally, we tell him, okay, your LDL level will probably have to target 1.8 millimoles per liter. Of course, if he doesn't know so much of that, you may have to sit down with him to tell him what the LDL readings are and what is the target that we're going to get to. And this is usually in the clinic setting for me, at least. I will tell them, I need to reduce your LDL to this level. It means this number of percentage of reduction if they can handle the information. Otherwise, if they cannot handle the information, I just tell them very simply, oh, I don't think this one medicine is going to be enough. It's likely they have to add on another one. So what I'll do is maybe give you some time to work through with your lifestyle measures, maybe watch your diet, lose a bit of weight. If the next time when you come back, right, right, where we repeat your levels and it's still going to be above 1.8, then we have a deal. We're going to start on ezetimibe, something to that effect. Of course, the CV benefit is very important. And then warning about the side effects so that they know when to present early. That's also very important. Okay. Now, how do we monitor and adjust therapies? That's going to be in the table and also the e-learn. We will have done a baseline, CK, lipid panel, and LFTs. Okay, so in case it gets confusing for you, there are some terms that we use for lab testing. Okay, so CK is usually referred to as creatine kinase, and that's the abbreviated version for creatinine kinase. Lipid panel refers to the whole panel that includes the HDL, the LDL, as well as triglycerides. For some places, they call it lipid panel. Some places they call it, there are some other names for it. But so essentially different places can call it different things. Okay, as opposed to some places you can actually order LDL as a standalone. And so it depends on what you're really managing. If basically at the baseline, your triglycerides are not raised, right, then there's actually no need to serially repeat the triglycerides with appointments as they come along. Okay, so baseline, you have done a proper workup with a full lipid panel. And then LFTs as well. If you use your liver function testing, right, if you look at your lab reference sheet, it's a whole host of liver function testing ranges. Like there's ALT, there's AST, there's also ALP. Okay, so what indicates for liver toxicities generally would use AST and ALT, and we've talked about this during e-learn as well. Okay, so this particular ALT, AST would be what you usually serially repeat if you think that someone is going to be at risk of liver toxicity. Okay, but if at baseline the LFTs are normal, then you actually don't really need to repeat LFTs anymore. However, if you adjust the statin or you start it for the first time, then you probably need to repeat the AST in about 4 to 8 weeks' time, along with the LDL. Okay, so that's how I wrote the answer this particular way as well. All right, so I'm not going to test your memory, don't worry. You just roughly know what the time frame is going to be like. Generally for cholesterol, when you start a drug or when you adjust a drug, right, you generally have to wait about 6 to 8 weeks for its maximal effect to kick in or optimal effects to kick in. But most of the time, you already start to see effects by week 4. So that's why it's reasonable to think about repeating LDL and AST within 4 weeks if that's going to be your appointment scheduling. Okay. However, you can also afford to wait 6 to 8 weeks later to repeat the LDL levels. Right? And then because generally you will repeat, you don't want to poke the patient too many times, you will cluster the blood test at the same time. You will think about repeating LDL and if needed, AST in that 4 to 6 weeks time or 4 to 8 weeks time, you see the patient again. Okay, so I'm talking about baseline and then repeating at the next appointment. All right. So for the time frame for 4 to 8 weeks, don't need to memorize, just know roughly when it's going to be. 4 to 8 weeks is a good range. All right. Unless you suspect that there's any issues. And we'll talk about that further later on with another case. Okay. Any questions at this time? Noah, I'll go on to the next case. Okay, so this particular table is again what I've stressed during e-learn, and this is a table that you roughly need to know. Okay, I don't need you guys to memorize the exact time frame, just roughly need to know the time frame that is reasonable to repeat. And this is different from the serum creatinine as well as potassium repeating of the blood test, right? With respect to how we would titrate the RASI agents. Okay, for the LFTs and for the CKs, just remember the how many times above upper limit normal is going to be abnormal. Okay, you don't need to memorize the exact steps. Like if CK is very high, what do you need to do? Just common sense. Anything more than 5, obviously got problem, right? Then you need to have some reaction. Anything less than 5, you just maybe wait for a while. Okay, and we'll talk about that later on. With respect to the LFTs, right? Remember I was saying during e-learn that the LFTs are commonly raised in patients with baseline, particularly if they have got fatty liver or steatosis, right? Because once you mobilize the fat with the treatment of statins, you actually cause a rise in the transaminases, which are ALT and AST. So it's not uncommon. However, if it rises to more than 5 times and 10 times, then obviously something is very wrong, right? So the number of times it's elevated upper limit normal is what you use as a gauge of how serious the issue is. That's why it's critically important to be familiar with the reference ranges and how people describe this in literature. Okay. All right, let's go on to the next case, which is Madam Lemah Manis. Okay, so for those of you who are good with Malay, you know that Lemah refers to fat and Manis refers to sweets, right? So this lady has got diabetes and hyperlipidemia. All right, so just to say what her history is, she has got diabetes with a new diagnosis of 7.8%, nil other medical history. Her LDL on presentation is 3.9 millimoles per liter. Her triglycerides are normalish at 1.5 and her blood pressure is still on the high side. Her BMI is not bad, 21. So which risk group does Madam Manis belong to? Who can tell me? Newly diagnosed diabetes. Who is ready? Are you guys referring? Okay, who's going to be the brave one to speak up? Come on, come on. Hello, hello. I'm waiting.
Is it high risk?
Yes, so she's relatively high risk, right? Because she's got diabetes. Oops, sorry. Yeah. So she's relatively high risk. You can consider her intermediate risk with respect to the ESC group, right? Because she has newly diagnosed diabetes. And remember, we were talking about how the risk is matched with the target. Okay, so this particular lady being intermediate risk, right? We will have targeted her with LDL levels of less than 2.6 millimoles per liter because she's newly diagnosed, okay? So once she has got one risk factor, right, then like maybe albuminuria or she's got peripheral vascular disease or long-standing diabetes for more than 10 years, then she's considered high risk. Okay, so this is what this table is trying to tell you. So remember, diabetes, not long-standing, no complications, generally LDL less than 2.6. Once you've got risk factors, then LDL level, target less than 1.8. Can? Okay, so that's where Madam Lemah Manis is. So because she doesn't have ASCVD, she's not the high-risk group of patients. She's considered moderate risk. What would her target LDL be? I think I already gave the answer, but what would her target LDL be? For those of you who saw it. Oi, what's the target LDL? Hello, hello? Joycelyn? Okay, Zhi Qian has answered. Okay, Joycelyn, what do you think?
No, less than 2.6.
Nice, Joycelyn. Yeah. So Jocelyn says less than 2.6. Zhi Qian also says less than 2.6 because she belongs to moderate risk, right? So again, matching the risk strata with the target LDL, all right? So what agent should we give her and what dose? Anyone? Anyone? How about Zihao?
A moderate intensity statin.
Okay, which one? And what dose?
Let me see. Atorvastatin, 20 milligrams.
Okay, I think you are fine with that. So we should probably reduce her LDL by 33%, right? That's why Zihao is saying we should give her moderate intensity statin. Nice one, Zihao. And if you look at the table over here, moderate intensity refers to this particular table. So you can potentially consider atorvastatin 20 milligrams is not a bad idea. You can also start with 10 milligrams, right? Or simvastatin 20 milligrams, okay? So again, notice here the relationship, right? Atorva is twice as potent as Simva, and therefore, if you are talking about atorva 10, the equivalent potency, equipotent dose of Simva would be 20, okay? Okay, so what would you monitor? Baseline CK, lipid panel, LFT, and then you repeat your LDL and AST about 48 weeks. So the drill is there, right? No need to go and try and memorize too much. It's the same thing, okay? All right, so is there anything else we can do for her today? Anyone? What else can we do for her today? Zhenqing. Zhenqing, are you there?
I think we can advise on her blood pressure.
What would you do? What's the target blood pressure, by the way? Can you remember?
Less than 130/80.
Nice job, Zhenqing. Okay, so what should we do? What should we treat her with, do you think?
As in
remember?
you're asking me to recommend a drug for her.
For her blood pressure.
Either a beta blocker or CCB.
Beta blocker? Does she have a compelling reason for beta blocker?
I don't think so. No. No respiratory.
Okay, so beta blockers are generally for what? Cardiac, right? Remember B and C, B and cardiology indications, meaning that if someone has an MI before, or if they had atrial fibrillation, they need rate control. So beta blockers will probably not be what we'd use for her, right? Remember what the first lines? A, C,
Wait,
D.
eight inhibitors, yeah.
Yeah, ACE inhibitors. Dang, dang, dang. Good job. Yay. Okay, so we'll probably do A for her, right? ACE inhibitors or ARBs. Why? Because she has diabetes, right? And diabetes is commonly, when they progress, associated with what? Someone else. Let's not put Zheng Qing on the spot. Jeffrey, what do you think?
Just prof.
I'm sorry?
Could you repeat your question?
Diabetes, as they progress, what is it commonly associated with? What would be a compelling reason to use ACE inhibitors or ARB for her?
As it progresses.
Mm-hmm. I'm helping you revise for exams, guys.
Is it like metabolic syndrome?
Okay. So metabolic syndrome is what at baseline before they even develop diabetes, right? But what's a common complication of diabetes? Can you guys remember? Okay, anyone can help, Jeffrey?
Or proteinuria?
Very good. Nice job. Yep. So proteinuria is also a compelling reason for ACE inhibitors and ARBs, right?
Yes.
Yes, thanks, Jeffrey. So that's why we would have considered an ACE inhibitors or ARB for her. And so Zheng Qing is very right. We would want to modulate her blood pressure as well, and also consider treating her diabetes, right? Because she's presenting with HbA1c of 7.8%. Okay, so essentially diabetes is what you're going to learn next sem, so I will not talk about it at this time, but just so that you can see how the cases all come together, right? The fact that someone has got lipids as well as high blood pressure issues. Oh, so many people wrote proteinuria and albuminuria. Thanks, guys. Yeah, so proteinuria and albuminuria are similar things, right? Because proteinuria in general just means protein in the urine, but albumin is a specific type of protein. So generally for diabetes, we would have measured albuminuria because they tend to be smaller molecules, because proteins can be quite large. So generally, we not look for proteinuria per se, but we look for albumin in urine. So if you hear those terms being used, that's why they're used interchangeably. But the more correct thing that we'll usually monitor for diabetic patients would be microalbuminuria. Okay, you don't have to worry about this in the next year, so don't worry about this for now. But the key thing is really how this whole thing comes together. Someone with diabetes is also commonly associated with hyperlipidemia as well as hypertension. And then there are many, many, many things that we can modulate about her. All right. So in this sense, it's like cardiovascular risk factors that we're managing. And this builds the basis for which you are going to get your lecture tomorrow on chronic coronary syndromes, whereby we're talking about CV risk factor modulation. Okay. So very commonly CV risk factors will refer to diabetes, hyperlipidemia, as well as high blood pressure, amongst many others. But these three are what we, as pharmacists, are likely to have the most contributions for, because we can track patients with time and we can adjust their medications. Okay. All right, let's go on next. So Mr. Gao Shuyat, this is the more confusing one. If you guys remember him from the hypertension series, right? Remember him, So this time, right, we're talking about his dyslipidemia, okay? His LDL is 3.9. So my question to you is whether he needs treatment. Okay, so the original notes, I had one original question, but I decided to just throw that away because it's not really relevant. So in context, right, we talked about the ESC risk score, as well as the ASCVD risk score for America. Okay, so that is actually quite hard to apply locally because the Asian validation is quite lacking. And therefore, the best thing to go with is probably the concept of the Framingham risk score. And I think you have heard this from Prof. Wee's lecture, Prof. Wee Hui Lin's lecture on Framingham risk scoring. And Framingham risk scoring was actually validated in a population many, many, many moons ago. And what they did was they put all these risk factors together and calculated the cardiovascular risk. And based on the cardiovascular risk, you decide on whether you want to treat patients or not. Okay, so don't need to remember what Framingham risk score is, just so that when you hear it, you know what people are talking about. So the Framingham risk score comprises of various components like you see here. total cholesterol, the age, the smoker status, HDL status, as well as the systolic blood pressure. Okay, so from here, people can calculate a 10-year CAD risk. And Singapore has actually localized it by putting the ethnic group inside there. It's just that I didn't put it up for you because I didn't feel like that was that important for you at this time. Okay, so based on Mr. Gao's profile, okay, can you guys remember from his profile, can you calculate his 10-year CAD risk score? How old is he? What's his total cholesterol? Smoker status? His HDL? And his systolic blood pressure. Okay, let's see who gets the answer first. You go back to his profile and then see his risk score. So you match his age. For example, he's 40 plus years old, right? 45 to 49, I think. His points is 3, right? Then if you go to total cholesterol, I'm talking about total cholesterol, not LDL, total cholesterol. And then you go by his age group, see how many points he gets, and you add all the points up. Okay, this is just exercise just for fun, just to give you an idea how to do this. Okay, who has the answer? Where's the answer? Gabriel, want to give it a shot? Oh, Gabriel, are you there?
Still calculating.
Oh, still calculating. Okay. Let you finish. Anyone has finished? Okay, Andrea has replied. Where's table 5.2? Huh? What table 5.2? Oh. Right. Later. Haven't come up with table 5.2 yet. That one is a spoiler alert. Okay, Andrea says it's 12. Okay, does everyone have 12? How did you get 12? These are the shaded out. Zihao says 7% is it? I think Andrew is referring to the number of points he has, and the answer is actually 12. So Andrew is right. And the 12 matches with the 10-year risk of 6%. So how would you get the 7? What was the 7?
Oh, I mislooked the header.
Oh, okay.
Yeah.
So the idea was to just get through the exercise of having his scores, his points at the points up, which is 12. And then you match that with the fact that he's Chinese, Malay, and Indian. And his 10-year risk is about 6%, okay, for his cardiovascular risk. That's how people have arrived or rather validated the Framingham risk score for local application. And his CAD risk score is 6%. So if you see 6%, where is it here? It's basically at the lowest rung. Again, ignore Singapore's guideline because it's just too far behind. The ESC tends to be a bit aggressive, but I think there's no wrong to probably offer him, to tell him that his cholesterol levels are a bit too high anyway. Because if you recall, the Singapore guidelines also talk about how the LDL levels should be actually reduced to less than 3.4 for those very low risk people. Okay, and if you feel like the person's at risk, like this guy is an ongoing smoker or he's got metabolic syndrome, as mentioned earlier by, I think, Jeffrey, the fact that this guy may require modulation of his LDL levels anyway. So again, it's a total package kind of assessment and then decision making. Okay, so just for information, this particular chart, don't worry too much. There's also a female version for it. Just now, the one that you used was for males. Okay, so don't need to worry too much about the particular charts because you probably won't be made to do this in practice anyway. So the question is whether his lipids require treatment. His 10-year risk is actually 6%. And his lifestyle advice is to stop smoking and diet modification for now. But remember that because age is the strongest risk factor of the CV risk, right? So because the longer you have been so-called floating with the LDL in your blood, right, the more chance it's had to happily put itself into your arteriosclerosis, your blood vessels, right? So arteriosclerosis is a cumulative problem with time, and therefore age generally is one of the biggest problem. And I usually would tell patients that if you get older, I can't modify that, but at least I can modify your LDL levels, and you can potentially try and stop smoking. There are many other things that we can modulate with respect to blood pressure and everything else. But again, the age cannot be modulated. But just basically tell them upfront that the risk will continue to accrue with time. Even if we do nothing, his risk will still increase with time. Okay, so the key idea is minimize all these risk factors as much as you can. All right. So this is a summary for the LDL lowering percentages. If you have got ASCVD, remember, diabetes or CKD, right? Your target LDL is going to be less than 1.8. Oh, sorry, this DM is supposed to be high risk DM. I missed that out. The target LDL should be less than 1.8 or less than 1.4 for the very high risk people. Okay, so I'll add in this very high risk DM here later on. Okay, so just take note, the first one is a mistake. The second one says no ASCVD, but maybe maybe a new DM. And if they have CKD, then you basically calculate the CV risk scores, or you tailor LDL targets accordingly. But most times you probably go for less than 2.6. And depending if how low risk, they don't have any compelling reasons, you would have done something similar to what we did with Mr. Gao and the Framingham risk score. Okay, so whether to treat hypertriglyceridemia or not, just to summarize, for high-risk patients already on statins and optimized, then you would still try to push with modifiable risk factors, because remember, the whole intent behind managing triglycerides is slightly different than LDL, okay? Because the treatment of triglycerides did not correlate with a benefit in mortality, whereas for LDL, you can see that correlation, that very nice line, right? So LDL is a no-brainer. You just have to go after it, chase it anyway. Whereas for triglycerides, right, you always try to remove secondary causes first, ask people to modify the lifestyle first, because a lot of times it's related with a poor lifestyle or somebody who has got metabolic syndrome, or if they're very fat, right? So then you consider starting a fibrate if the TGs, fasting TGs for this matter, is more than 2.3 millimoles per liter. Okay, now if it's a primary prevention type patient, like maybe it's a familial hypercholesterolemia, doesn't have ASCVD or diabetes or anything like that yet, still modify lifestyles and still start statin if TGs is more than 2.3. Okay, so anything that has got high risk, including FH itself, is still going to be quite aggressive. If the person's TG is 4.5 millimoles per liter, so if anyone remembers 4.5, why is it 4.5? Basically, because of the Singapore guideline. But if you recall, the pancreatitis cutoff is really 5.6, right? So generally, anybody with very high TGs that the statins are not going to be beneficial for them, you will have thought about starting a fibrate as first line, right? Because firstly, the person's at risk of pancreatitis. And then the person's, if you use statins alone, right, it's not going to take the TGs to comfortable enough level of less than 2.3. Okay, so in this case, when the TGs are urgently high, you want to consider fibrate as first line. And then again, lifestyle, as I think someone mentioned earlier, I think it might have been, I can't remember who mentioned it, but the lifestyle is very important, especially diet, because for triglycerides, on contrary, as opposed to LDL, lifestyle modification of, reducing saturated fat, keeping the weight down is very important. And if someone has got poorly controlled diabetes, that's also important. You've got to control diabetes well. Okay, and then add the statin later if indicated, right? Because remember, sometimes when you treat triglycerides, right, you do see a phenomenon where the LDL starts to rise. And this is to do with the lipid cycle as well. Okay. All right, I will give you guys a break. We have bash past 11 a.m. We maybe come back at about 11:15 to do the rest of the IC. Okay, see you guys in about 7 minutes. Go for your bio break. Anyone has questions, go ahead and ask them. I'd be happy to take them. All right, see you in a while, guys, 11:15. Yes, Yahao? PCSK9 inhibitors?
Yeah, hi, Prof. So, you mentioned like for primary prevention, right? The patient has let's say familiar hypercholesterolemia, right?
Yep.
Is it that you override the algorithm? So you give PCSK9 inhibitor like straight away?
That's for the very high risk FH patients. And essentially by risk, you would usually look at the some criteria lah. Yeah. So based on the criteria, you determine whether they're very high risk, especially those who have got premature heart disease and all that. You probably want to be aggressive about treating them up front. And those who present with very, very high LDLs of like more than 9, more than 20, that type, right? Those are the types that you know you have to be really aggressive, and statins are not going to get them to goal anyway. Yeah, but generally, if you think that they're FH, you got to work them up properly first, like send them for genetic testing, that first to establish that it's true that they do have FH before you decide on giving such a high cost drug. Yeah, I hope that answers the question. I have a slide at the back actually, but I would say don't worry too much about FH for the purpose of the exam, because it's I guess a specialized group of people that the endocrinologist specialists would have dealt with. But it's important to know the concepts behind why you use PCSK9 inhibitors. I used to think that potentially that could be a role because some of these FH patients have got a mutation with that gene, right? And they really just have very high levels of PCSK9. That's why it would indicate the use of PCSK9 inhibitors. The trouble though is if you use PCSK9 inhibitors long term, right, it's going to be a very costly affair. And I don't think very many people can afford it. I mean, I don't think I can afford it, let alone a normal person on the street. So that's also why it's not really highly practiced today. Yeah. I hope that answers the questions, Yahao.
Yeah, thanks very much, Prof.
Yeah, no worries. There's also a group that is the homozygote type, right? That no matter what drug you give them, poor things like they still don't respond very well. So those are the people that you need to send them for some sort of like a blood exchange, almost like the dialysis version of blood exchange, plasmapheresis, in order to like wash out literally all the LDL in the blood. Yeah, so it's quite sad for those people. Some of them can even experience heart attacks very young, like 20 plus years old. Yeah. So the whole hypothesis with cholesterol, I feel, is real. So I do think that we need to have a campaign to recognize LDL and the importance of its treatment a lot earlier. I feel like our primary care is not exactly doing very well with respect to that, because a lot of times it's probably influenced by the fact that the Singapore guideline still has been like 2016. It's quite dated. Yeah, so I think we do need to be a lot more aggressive these days.
Okay, understood.
Yeah. So hopefully you guys go out there and change the world, okay? I train my pharmacy students well so they go out and change the world. Okay, welcome back. All right, let's talk about Mr. CK. Obviously, the name is a play on creatine kinase. So Mr. CK is a 43-year-old and he is a physical education teacher and a part-time coach, right? Look at him, he looks super fit. He's got background of familial hypercholesteremia. His baseline LDL is 5.7 millimoles per liter. He's been started on rosuvastatin 20 milligrams ON 2 months ago. So he's back to see you in the lipid optimization clinic. And this is his labs today. Basically, LDL 2.6, CK is 1004. His LFTs are within normal limits. WNL refers to within normal limits. Blood pressure wise, pretty well controlled. Pulse rate, nice. And his BMI is nice, quite within the expected range. Okay, so for this particular exercise, what is the number of times above upper limit normal? Where's the answer? Hello, all back with respect to your break or not? How many times upper limit normal is this, CK? Anyone? 4? Okay, yes, Celine, thanks. It's 4 times upper limit normal. So this was the reference range that I gave you guys in your notes in the e-learn. And it's about 4 times upper limit normal. So Celine is absolutely right. So what type of information would you solicit from CK at this time? Oops, I give you the answer. What type of information would you solicit from CK at this time? Anyone? What would you ask him? Yashwini, what would you ask him?
I would ask him if he has any sort of like intensive like exercise that could indicate any sort of muscle injury.
Okay, nice. So you ask him whether he's done vigorous exercise and all that, right? Nice.
Yeah.
Okay, thanks. How about Afifa? What else will you ask him? Afifa, you there?
The same thing. I don't know, maybe about his.
If you look at CK this level, what would you be worried about?
Is it high?
About what?
Is it high?
Mm-hmm. So what would you be worried about? Like what could potentially threaten his life or his well-being?
Muscle injury, is it?
Mm-hmm. What would be the sign that you would see?
The color of his urine.
Very nice. Thanks, Afifa. What's the color of the urine if he's got rhabdomyolysis?
Red or brown.
Yep, that's right. So even though he doesn't present any symptoms, you ask him whether he's got some muscular symptoms like muscle aches or pains or weakness, right? So Yashvini also wants to check whether he's done any rigorous exercise. That was very good thinking. And so Afifa has said that if you're looking for rhabdomyolysis, you look for urine that is red to brown, right? That is the coloration because of the myoglobin that has caused acute renal failure. And because it's got heme in it, so it colors your urine red to brown. That being said, you can actually have rhabdomyolysis without having red colored urine. Most times when you have red colored urine, you do need to be very careful and send the patient right to A&E. So that's why that's one of the counseling points that we tell our patients. Okay, so basically the answer was to ask whether he's got muscular symptoms, red brown urine. Yashmi is right, asking whether he's got intensive exercise. I remember that I was running a lipid clinic years ago. I had this patient, something like this, Mr. CK, also about this age, and he was a dragon boater. So he was referred to us because his LDL was like that, very high. And he's also got some high triglycerides. So he was on a combination of, if I remember correctly, a statin and fibrate as well. And then one day he came in, right? His CK was so high, it was unreadable. It was like more than 9,000. So it was so high that even our labs couldn't read it. And then I was like, I looked at him and he looked so well. So if someone has rhabdomyolysis, they will look very unwell, right? Because of of all the metabolic changes, their electrolyte changes, they'll be unstable. But he looked so well. He was just sitting there and smiling at me. So I was like, do you have muscle pain? And he's like, no. I was like, do you have red brown urine? He was like, no. Then, everything that I asked him was no. So I was like, so did you have gone through any sort of intense exercise or anything like that? He's like, nope. So I was like, what do you do over the weekend? He was like, oh, I was training and I did this rowing for 14 kilometers and then we were doing weightlifting and that stuff. I was like, oh, so that's not vigorous to you. And I think that's important for us all to realize that because, sometimes that's why the importance of asking the right questions whenever we're gathering medication history or medical history from a patient, because like to a dragon boater, that's not vigorous exercise, that's his usual training. So when I asked him, do you have vigorous exercise? He said, no. Then so I had to ask him, what do you do yesterday? What do you do over the weekend? In order to solicit all that. Anyway, the long story short was this particular guy, I had to present him to the endocrinologist in charge. We didn't admit him in the end because he's just so well. So we asked him to get home, hydrate himself, make sure that he drinks a lot of fluid. And we got him to come back in about 2 or 3 days to repeat his CK levels in order to make sure that his CK levels were back to normal or at least on a downward trend. Remember that there are many things that can cause a CK to rise, right? Things like even those of you who like to go for thigh massage, right? Somebody who goes and crushes your muscle and massages very vigorously can also cause a CK to rise. But for it to rise like more than unreadable levels is obviously quite unusual. So for someone who has done vigorous exercise, and if they appear very well, you really don't really need to do very much about admitting them or anything like that. So it's important to triage through how the patient presents, and then you make your decisions from there. Okay. So the question is, how would you handle this? So I guess similar to what we're talking about, if it's like completely well, we probably won't worry about having to admit him or anything. However, if he had these symptoms of the of muscle, like very extreme weakness, red brown urine, he was unstable, he looks very unwell, then that's when you want to admit the patient. Okay. So for the purpose of this guy's LDL levels, do you think that non-pharmacological advice would help him? I unwittingly gave you guys the answers. Would this non-pharmacological advice help this gentleman? Does anyone think? What do you guys think? Oh, nice, Andrea. I didn't see your response and urine discoloration. What are the non-pharmacological advice do you think is going to help him for his LDL levels? Anyone? Tomiko, what do you think? Tomiko thinks diet can help him, you think, for his LDL? Okay. What about Haley? What do you think, Haley?
I think probably no.
You think won't help him for his LDL?
Yeah, because it seems that he has very healthy life.
He looks like, right? Yeah. But he could also be unhealthy lah. He could be taking a lot of fried foods. So I suppose we could still try and find out from him what he exactly eats, and then also try to modulate saturated fat and all that stuff. But as talked about during our non-pharmacological e-learn, right? The modification of diet doesn't change that much in LDL level, but it does modulate the TGs quite a bit, right? However, the weight loss, particularly someone who's very fat and obese, that kind of a patient population, or maybe if they have got metabolic syndrome, then those are the people whose diet modulation, particularly high saturated fats foods or a lot of animal fats, those are the people who are going to benefit from dietary modulation. Okay, that being said, you still should encourage patients to a healthy lifestyle. For this particular man, it's going to be very difficult. But I just wanted to use Mr. CK to show you guys that it's not entirely impossible for someone to have abnormal lab enzymes and still be very well. Okay, so it's important to consider your patients holistically. Okay, next question. Okay, so here I wanted you guys to take note about the CK abnormalities. I don't need you guys to memorize that particular very complex chart over here, huh? Just know roughly what's the 5 times cut off, right? The threshold is 5 times. And because he belongs to this group here, that's CK less than 5 times, right? You don't really need to do anything about his therapy, but get him to come back to repeat his levels. So if it's anything higher, you probably need to think about stopping the statin for a while. And then remember to also assess for rhabdomyolysis as well, just to cover your backside, especially if you're the person who is seeing the patient at the time. Okay. All right, so again, a reminder on the monitoring chart, which I will not again belabor. However, again, don't need to memorize the time frame, but you need to know what are the labs that you need to monitor for your patients. Okay. Okay, so quickly going on to drug-drug interaction, and I will tell you that I will never be able to extensively or comprehensively cover drug-drug interactions for all of you. So I'm just going to give you the concepts and then teach you how to fish, and then you guys can go and fish by yourselves, okay? So if you recall the basis for DDI for statins, okay, I won't say recall, you probably don't know this yet, but the most important basis for DDIs for statins, and you will learn this more in liver in the next semester, is that the CYP enzymes, the CYP450 isoenzymes are probably the most important mechanism, not being the only ones, but the most important ones, okay? Because the 3A are a lot of times the substrate for most of the statins, with the exception of rosuvastatin, pravastatin, and we don't have in Singapore pitavastatin, which is CYP2C9, okay? So 3A4 is the most common substrate for a lot of our statins, and therefore, because a lot of drugs are either inhibitor or inducers of 3A, it becomes quite a lot of problem, okay, with respect to the use of statins. Okay, that is a key point that you must know. The other enzymes are also frequently involved, like 2C8, 2C9, 2C19, and 2D6. But the most common drug-drug interactions will always be with 3A. The drug transporter enzymes like PGP and OATP are now becoming more and more important. And what this does is these transporter enzymes usually excrete the drug from your body. It's either they dump it into your urine, or they block the absorption, or they cause the gut absorption to be re-efflux out into your gastrointestinal space, and therefore you do not absorb the drug that well. So whatever it is, the transporter enzymes are supposed to protect the body by not taking it up or dumping it out. So any sort of mutations or blockade of it will actually cause a rise in the level of the drugs inside your body. And then depending on which direction it's going to be, it can also cause increased excretion of the drug from your body, or elimination of the drug from your body. So I just wanted to show you the interrelationship between statins and other molecules. So on the right-hand side, the color ones is other molecules. So a lot of the statins are substrates of the CYP enzymes. Okay, and many of these other molecules are either inducers or inhibitors of the CYP enzymes. And therefore, if they're inhibitors, they'll sit on the CYP enzymes. And therefore, your substrates, which are going to be your statins, are not going to be broken down as easily. And therefore, the levels of your statins will rise. Okay. On the other hand, if anyone was inducers, they'll cause the CYP enzymes to break down faster or more extensively. And therefore, the levels of the statin in your body will decrease. Okay. So interrelatedly, your statins can also be substrates or inhibitors of the same CYP enzymes and can cause problems with the other substrates as well. Okay, so there's an interrelationship, but most of the time, because statins are generally substrates and not very strong inhibitors, you don't get as much problems with the other way around interaction. You get a lot more problems with people who are what we call perpetrators, who are inducers or inhibitors of enzymes, and it causes more problems with statin as the victim drug. Okay. So this is a table of potentially interacting medications with statins. You look on the left-hand side, a lot of anti-infective agents. So that's why you would explain when you see people who are critically ill, right? A lot of them are at risk of also rhabdomyolysis, because a lot of times they may be on statins and then a lot of these drugs are being used in them. Some of these are used in the ambulatory setting, like for example, clarithromycin. And a lot of our HIV patients are also ambulatory. So those are protease inhibitors that you need to think about and watch out for. Again, these are inhibitors of 3A, and that's why there are problems. Okay, so I will not go too much into detail of the azoles. You'll probably cover it under infection control next year. The other groups that you're more familiar with that we've covered in cardio are actually calcium antagonists, verapamil, diltiazem, and amlodipine. And again, they are also inhibitors of 3A. There may or may not need to be actions that are taken. So we'll talk about that later. So just know about the theory first. Lastly, there's a group of miscellaneous agents, and you can see amiodarone is over there. Now, amiodarone is a massive drug interactor with is a massive perpetrator with many enzymes, because it blocks 3A, 2C9, 2C19, 1A2, and many other CYP enzymes, thereby causing it to be a huge perpetrator of drug-drug interactions, not only with statins, but many other agents as well. Okay, so if you recall, Dr. Chang talked about drug-drug interactions. This is why, okay? The other things that you want to maybe have a look there is gemfibrozil. So if you recall from Elon, we talked about the fibrates, right? The fibrates that have got drug-drug interactions that's significant with statins are actually gemfibrozil and bezafibrate, which is not really available in Singapore, so don't have to worry about it. But we can potentially consider the use of fenofibrate if we ever need to add a fibrate to statins, for the reason that fenofibrate has got less of a drug interaction with the statins, okay? So if you recall, again, this is a key point that I wanted you guys to remember. No gemfibrozil is statin, but okay with fenofibrate is statin. And lastly, grapefruit juice. You might see a lot of the counseling points in, say, UpToDate or many other websites that talk about grapefruit juice and statins. Now, interestingly, grapefruit juice is an inhibitor of 3A. Okay, so if you take grapefruit juice and it interacts in your gut space with your absorption of your drugs, right, it can actually cause a reduced excretion of your drug from your gut space. So it's an interaction that's very interesting, but I won't go into very much detail. Just know that grapefruit juice can interact with statins if you take them together at the same time, mainly because of this inhibition physically in the intestinal space. Okay, so for people who take a lot of grapefruit juice, we do tell them to space apart from the statins as much as possible. And remember, your gastric emptying time is about 4 hours, right? So as long as you space it maybe half a day apart, you're probably fine with that particular aspect of things. Okay, so it's not just drugs that interact with drugs, there's also foods that can interact with drugs. So this is an extensive table. Again, please do not ever go and memorize this thing because you can refer to that in literature and I will not test your memory, so don't worry about it. But remember that the enzymes involved are these ones. Okay, I don't need you guys to memorize this at this time, but this is a concept that I need you guys to start to think about because under liver, you get a lot more of these drug-drug interaction concepts that will come up front. Again, the OATP and PGP, you might not cover it very much in liver nor in kidney, but it's an increasing concept that we need to consider as well. Okay, so where lava, Atova, and Semva are concerned, we are talking about a CYP3A4 enzyme. Most number of drugs are being metabolized with 3A4, and therefore, any of the drugs that you think are inhibitor or inducers of 3A4, please look them up to look at the impact of the interaction. So for amiodarone, you see amiodarone is everywhere, right? It's also even a PGP inhibitor as well. So it becomes like a huge impact whenever amiodarone is being used. And potentially you will heard from Prof. Tree about red yeast rice, which is actually found in hypocol, and that's found over the counter. Remember, red yeast rice is literally the same as lovastatin. All right. So if you use red yeast rice together, please be very careful to watch out for drug-drug interactions with your current statins as well. Okay. So how do you look up drug interactions? Here is a screenshot from UpToDate. You guys can play with this yourself. If you go to the drug interactions function, you can enter the drug's name by name, and you can hit the button called Analyze, and you get this particular page on the right-hand side. Okay. Then you look at the grading or categorization, X or D or C, right? It'll tell you what to do with these drugs. Okay. Each drug has its own advice, and it tells you even the mechanism or the suspected mechanism why there are drug-drug interactions. All right. So please don't try and memorize, but just know to recognize when there's potentially interaction and then look them up one by one. Okay. So these are the details behind it. I won't go through this. I will not test you this during exam. Okay. So I just need you guys to know this just to be prepared for either the practice that you come in NUP that's coming in PCT, and then start to think about this when you go into liver as well. Okay. Same thing for amiodarone and statin DDI. Somebody asked me the other day. So just to let you know, the interaction is probably significant with simvastatin, but we probably don't need much action with atorvastatin. Okay, for the reasons you can go look up UpToDate yourselves. Colchicine and statin also have got drug-drug interactions. I need you guys to be very aware of that because a lot of times with the people with metabolic syndrome, they also have gout, right? It's probably a lifestyle related thing. And so I need you guys to know that colchicine is also associated with musculoskeletal side effects. And if you've ever seen colchicine, particularly taken regularly with a statin, you might need to think about how you want to manage this. Now, I got very upset with one of my young pharmacists one day because there was a patient who was started on colchicine by rheumatology because he's got gout. And this was my patient that I saw about a month back when I next saw him in clinic. So this time that I encountered him was one month down the time that I've seen him in clinic. And the first time that I saw him in clinic, right, actually he has a lot of problems taking statins because he again was buying into all those fake news that statins are bad, causes a lot of this and that and everything else. And he decided not to take statin at that time. So I managed to convince him to restart his statin, only to have him get started on colchicine by rheumatology 2 weeks down the road. Of course, this was unknown to me because the patient went to pharmacy to collect colchicine. And this pharmacist was well-meaning, told the patient there's an interaction with colchicine, and told the patient, oh, you know, you have muscle ache and pain, no, don't take the statin. I was like, oh my Lord. So when the patient came back to see me in clinic, 1 month down the road, I was expecting to see his LDL drop nicely. I was quite upset when I found that his LDL was still almost 4. It was, I think, 3.9 or 3.7. I can't remember exactly what it was. And I was very upset. And I asked this uncle. Uncle was actually a very confused patient somehow, you know. It's like every time someone tells him a new thing, he will probably believe it, right? So I asked him, why do you actually stop the statin? And he said, oh, the pharmacy told me that if I take this together, right, it's going to cause problem. So that's why I decided to stop. And the pharmacy told me to stop. And he swore that the pharmacy told him to stop his statin, right? So, I mean, suffice to say that anytime when you tell patients and it's convenient what they believe in, they will just believe the next person, the next random person, right? Essentially, I only kick myself in the backside for not asking him to check in with me before he stopped any medications before that. However, thank God it's a statin, which is not like life-threatening that he didn't take it for the last 1 month kind of thing, right? So I made him restart it and explained to him this was an issue, and essentially also dealt with whoever the person was on the ground who dispensed the medicine to him to please not scare patients this particular way. Okay, so for those of you who want to know how to tell patients nicely, I'll be happy to take your questions after this. But suffice to say, please think about how you want to give messages to patients such that it doesn't scare them off medicines that can save their lives. Okay, so this is an inset for how colchicine affects the patients, and it usually will become a problem only if patients are mildly impaired with respect to renal function. Okay, so these are the non-statin DEIs, which I will not spend too much time trying to memorize. I just need you guys to know, in case you see this in practice, cholestyramine binds other drugs, and so it's important to space them apart physically with the other medications. And with every drug that you are dealing with, there may be different time intervals that you need to tell patients to space apart. And it's a huge pain with cholestyramine because it's used 3 times to 4 times a day. Now, all you need is a drug that's used 2 times or 3 times a day that is the interacting drug, and you're going to get a lot of trouble trying to space the medicines apart. That's why one of the reasons why cholestyramine is hardly used today, because there's so many other agents that are effective and less troublesome for its use. Okay, so GI, again, side effects, GI is very common with cholestyramine. So that's just what you basically need to know about cholestyramine. GI, side effects, the administration, and also the troublesome drug-drug interactions that come along with it. Omega-3, I mentioned in the ELEARN, has got antiplatelet effects and therefore increased bleeding risk theoretically. Okay. So this last part is actually not going to be all that important to you with respect to the exams, but I just wanted to give you some sense of what goes on the ground when you encounter them in practice, or when you go over to PCT, you know why people say things this particular way. Now, I do want you guys to pay attention to the elderly and the pregnant population, because that involves contraindications which you need to be aware of. Okay, so this is familial hypercholesteremia, which Dr. Mitchell Lai went through with you yesterday somewhat of. And you would see people with FHs commonly presenting with these issues. So the issues of xanthoma, which is like fat cells, which actually when you touch it, it's like really fatty. You can feel like it's fatty on the skin. The one at the bottom of the knuckles is also xanthoma. The one in the picture in the eye is called the arcus, and there's actually fatty deposits in the iris of the eye. And then at the bottom is where you have xanthelasma, and those are commonly seen in people with very high LDLs, and it actually has fatty deposits in the eyelids that's called xanthelasma. Okay, so these are very big hallmarks of FH patients. So they can present with very high LDL TG, so very low LDL and HDL levels. And again, this is why we call the whole plethora of this abnormalities, dyslipidemias now. There's 2 types, heterozygotes as well as homozygotes. And I'm not an expert in that. Please don't ask me more questions. I only know these facts. So heterozygotes generally develop a coronary heart disease very young. Okay, so when you're looking at someone with the history and you're talking about Mr. CK, for example, right? If his father had a heart attack at less than like 50, 55 years old, right, then he becomes a very high-risk FH. And this is related to what Jiahao asked me earlier. Okay, so those are additional risk factors you might want to consider thinking about treating them with PCSK9 inhibitors or not. Okay, so it's critical to diagnose these patients early and treat appropriately. And the prevalence actually is not that low in Singapore. It's probably 1 in every 200, 250. And it's thought that we are underdiagnosing these patients because we don't know about them until they come in with a heart attack, and then we find that, how come the LDL levels are so high? Okay, so there's also this other group, which is homozygote FH. And these guys can develop heart disease by about 20 years old, and they die before 30 years old. And these are very sad. So for this particular group of people, it's very important that we identify the children early. These people may be required to undergo plasma apheresis, which I mentioned earlier, which is actually literally washing out of the fat from their blood. And if for those of you who are interested in FH, there's actually a link, there's a group in Singapore that advocates for it. One of the things that is important is to talk about public education. And for people who are at risk, particularly parents who want to have children, there needs to be some genetic counseling and also cascade screening. So I remember I had a patient like that. He had a heart attack at 41 years old, and his LDL levels were so high, even with high-dose statins and ezetimibe, I couldn't get him to go. And I did offer him PCSK9 inhibitor, and this guy had difficulty affording it. And so I had to refer him to research service in KDPH in order to get him seen and maybe subsidized for PCSK9 inhibitor. So when I asked him, I said, hey, so who else in your family? What does anyone else have heart disease? And he told me, oh, my father died of heart attack, and he was like 50 years old. I said, oh, wow, okay. Do you have siblings? He says, yes. So I said, what about your siblings? Any heart disease? And he said, yeah, my older brother had a bypass. And this is a man sitting in front of me with heart attack, 41 years old. So I said, oh, wow. Okay, so what about the rest of your siblings? He said, I'm the youngest of 5 siblings. And all 4 of my siblings have got high cholesterol, but only my elder brother has gone through bypass. And this is the importance of cascade screening, right? Because if you catch them early, you can prevent these issues early. And it's important to even treat them early as well. So the older patients, a lot of times you find people shunning away from statins in the older population. And the facts behind this is that the absolute risk, right, you must know, absolute risk for heart disease, I mentioned earlier, increases with age, However, right, there's no direct evidence for statins beyond 75 years old. And it's also because how the randomized controlled trials recruit patients. But that being said, it's been seen even in older patients where we treat LDL, right, there's still benefit to them. However, the problems with the older population is firstly, they're very sensitive to adverse effects of any drug, let alone a statin. And even my own mother-in-law has been complaining about muscle aches and weaknesses with the statin. But her LDL is so high, there's no way we can take her off her statin. And so she is the one that an endocrinologist specialist has given alternate day rosuvastatin for. And that took her LDL down very, very nicely. She's also got diabetes, by the way. And so because in the elderly, they're so predisposed to a lot of comorbidities, right? They also take a lot of medications. You might want to be very careful about drug-drug interactions that you see in this patient population, as well as these ADRs, which are very, very common in the elderly. To start with, they're older, right? So they already have weakness. So it's very challenging to try and tell apart whether it's due to the drug or it's due to their aging effects altogether. What about women and pregnancy? Now, women are underrepresented in clinical trials for obvious reasons, because why ethics will tell you, oh, you want to recruit women, you must make sure that they are not pregnant first, you must test them, blah, blah, blah. So it's very troublesome to recruit women, and especially those of childbearing age. But however, in this cholesterol treatment trial list and basically meta-analysis of many studies, it's been shown that we know that LDL reduction is still going to be beneficial for women, no matter how small a population there is in clinical trials. And statins are still going to be beneficial for women. The benefit in women are still going to be the same. So in other words, we still have to be aggressive with women as well, not just men. The benefit of ezetimibe, fenofibrate, and PCSK9 is also similar in both gender. And the trouble is that for women who are pregnant, we can't use statins, we can't use ezetimibe, we can't use fibrates, and we can't use niacin. And there is no data with PCSK9 inhibitors. You can only use our very boring and very troublesome bile acid sequestrations, which can cause them nausea, which can cause them burping. And this already is very troublesome for them when they are pregnant. So this becomes a very troublesome situation, very tricky to manage. The other thing you have to also remember is statins pass into breast milk. And you probably need to think about the implications on how old the baby is before you decide on whether the benefits versus risk-wise is beneficial for someone who's breastfeeding. So the standard thing is if someone has got FH, you're really in a tight spot, right? You probably need to think about giving statins early. And then if they want to conceive, they have to inform their prescribers so that there's a proper cessation of statins at least a month before the attempt to conceive as well. And so those are intrinsic problems that we have to deal with the female population. So the trouble also is during pregnancy, right? The LDL can increase, the triglycerides can increase. That it poses quite a big conundrum for people with familial hypercholesterolemia. So I'm not an expert in this, so I can't help you with this. If you really want to know more, you probably have to speak with gynecologists who are also experts with endocrinology in that area. The key thing also with FH is that they can pass a gene to baby. And what happens if you have to continue statins in the postpartum, right? The benefits versus risk. What are, about the breast milk secretion and what are the implications that we need to deal with? So there are a lot of tricky situations that we require the inputs of specialists dealing with women and pregnancy as well with respect to treatment of cholesterol levels in women. Okay, so let's end off with a Kahoot before I start to show you how dangerous the world is. Okay, so restart your Kahoots now and log in. So at the last we saw, YD is still in the lead, and so let's see who is going to topple YD this time. Okay, are you guys ready? Question 6: when would LDL be repeated after initiation or adjusting statin dosing? All right, let's see what you guys think. Within 4 to 12 weeks. Actually, the answer is within 4 to 8 weeks in general, but okay, I'll accept 4 to 12 weeks as well. So okay, 4 to 12 weeks count. Let's see who is on the leaderboard. It's still YD. Okay. Okay, next question, question 7. A man with a history of ischemic stroke and baseline LDL of 3.9 should receive. Okay, equal numbers for high intensity statin 20 and Atova. Okay, that was a trick question because Atova 20 is not high intensity, it's only moderate intensity. High intensity Atova is at least 40 milligrams and above. So the correct answer is rosuvastatin. All right, let's see who is in the leaders. Oh, still YD. Nice job. Okay, question 8. So diabetes patients, baseline 4.1 millimoles per liter of LDL. What are the following possible options? Okay, this one I gave you 30 seconds because it requires calculation. Okay, so the correct answers are supposed to be either 10 milligrams Atova or 37% reduction that's required. I think some might have gone for Rosuva 10. Also not wrong. Can be considered an option as well. So don't worry, with your exams, I will not give you such tricky questions, okay? Just to test your clinical applications. Okay, let's see who's top. Still YD, nice. Let's see with the last few questions who can topple YD. Question 9, rank the statins in order of increasing potency. I give you 1 minute for this one. Let's see what you guys come up with. Half a minute to spare. Oh, looks like you're all in. Oh, still got someone answering. Okay. Shouldn't I give you so much time? You all can refer to your notes. But still, the fastest finger wins. All right. 10 seconds left. Okay, that answer is 63% of you got it wrong. No, why? Okay, so the answer should be rosuvastatin the highest, atorvastatin is next. Oh, I see. I went it the other way around. So the 63% actually got it correct. It's decreasing potency. Okay, so the highest potency is Rosuva, Atova, Simva, and Lava. Actually, I don't know which order it's showing. So maybe let me know what the question is asking you. Sorry, it's a badly set question. All right, still YD is top. Okay, very nice. I don't know whether YD got the red or the green just now. Okay, last one, statin drug interactions. All in good fun, guys. All in good fun. All right, so what about statin drug interactions? Last 1 minute and we are done. Okay, correct answers were red and green. So many of you chose blue. Occur with amiodarone. Okay, yes. So I gave you all the impression that it occurs with amiodarone. They don't always require modification of statin doses. For Simva, yes. For the Atova, not so much. So if you look at the ranking that we talked about earlier, actually Atova only requires monitoring, doesn't require modification. Essentially, they do interact with P-glycoprotein and OATP1, which are the protein transporters that we talked about. And there could be diet drug interactions with grapefruit juice, as well as red yeast rice, which is actually a nutrient drug interaction as well. Okay, yeah, so they don't involve only 3A4, right? Because there are a couple of statins that are metabolized by 2 2C9 as well. Okay, so it's not just the only isoenzyme that's affected. All right, let's see who's tops on the podium. Number 3, third position is QQ. Who is QQ? So cute. And second is YD. Oh, someone toppled YD. Who is in first place? Let's see. Panda. Congratulations. Okay, Panda, please email me for your prize. Okay, good job, guys. Let's silence this thing. Okay, I'm actually done with the IC today, so I'm happy to take any questions for anyone who might have any questions. Otherwise, the rest of you can go ahead and rest for the day because there's going to be graded skills lab in the afternoon. I'll see some of you in skills lab later. Okay, any questions, guys? Those who want to leave can go ahead and leave. Anyone?
Hi, Prof.
Yeah,
Can I
hi.
ask, right? So for the CK, right? When it comes to the the SAMs, right? So as long as it exceeds the upper limit normal, right, then we have to ask about the red flags, is it?
Oh, you mean the moment it's become more than upper limit normal? I mean more than like the 350, is it?
Yeah.
I generally will to cover my ass, but it probably is not going to be significant unless it's more than 3 times upper limit normal.
Oh, because I thought it's like if it's more than 10 times, right, which is the sign for myositis, right, then you ask for the red flag.
Yeah. So it's just to cover your ass lah. But essentially you don't really, I mean, like what's the harm of asking for red flags anyway, right? If you had a lower cutoff, you know what I mean? It's also to make sure that you will have covered your ass in some area. But you're right in that the CKs need to be a lot higher, like maybe 5 to 10 times upper limit normal before it's associated with myoglobin release as well. And that's when the myoglobin can cause this rhabdo sign, which is the red coloration on urine. So you're right, Jiahao. I would say that theoretically, there's not that risk until more than 5 times to 10 times. But in practice, I still would have covered my ass. But asking for those symptoms. Yeah. But in any situation, you should always be asking for muscular weakness or pain, right? Because there can still be myositis. It's just that it's not rhabdomyolysis. Whereas when you have red colored urination, you definitely need to admit the patient because you will suspect rhabdomyolysis. So it's more like a kiasu kind of thing lah. Yeah.
Okay, thanks, Prof.
Yeah. I don't have such questions, don't worry. Anything that's subject to clinical judgment, very hard to set MCQs, so you're quite safe one. Okay, Tomiko. Tomiko is asking, other citrus fruits such as clementine, pomelo, or mandarin cause similar DDI. Interestingly, I think pomelo does, but I think the other clementines and oranges, no, they don't. If I remember correctly, pomelo does, but you might want to look it up and let me know if I'm wrong either way. However, grapefruit juice is something that you see in literature everywhere. You even see it in the Angmo literature, the European literature or the Caucasian literature, because grapefruit juice is a lot more used in the Caucasian population than local. Our locals don't seem to like grapefruit very much, I think, because it's too bitter. Our locals seem to like sweet stuff. Yeah, good question. Thanks. Zheng Qing is asking, for younger patients with SH, are they still indicated for statins? Okay, so the easy answer is I would say yes, mainly because PCSK9 is just going to be too expensive for them. So you probably would have still tried to give them statins first as a first line. Yeah, but most times it's going to be hard, especially with those with very high LDL baseline, to get them to even a decent level of less than 3. So you probably need PCSK9 inhibitors anyway, and it becomes a very difficult social problem when it's for primary prevention, meaning that you don't even have cardiovascular disease for anyone to even think about funding these patients. And as I mentioned, PCSK9 inhibitors can cost you up to like 600 a month in the restructured hospitals. It's not easily obtainable. And in the private setting, it can cost you up to $1,000 a month. So I don't see very many people who are able to afford that. Yeah, so like my patient, what I did was I referred him to a research service. And so I just pray that he gets covered at least for the 1 year that he's involved in that research. And then with the cascade screening, the whole family can be also genotyped, and that also informs them for the next generation rather than let them be swimming around with high LDL levels. Yeah. Okay, any other questions? You're welcome, Tomiko. You can look it up and see whether I'm right or wrong. Yeah. Any other questions, guys? I'll just count to 10 if there are no other questions. Panda, please email me, whoever you are. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay, I guess no other questions. Thanks, everyone. See you guys in lab in the afternoon, whoever's going to be there. Break a leg. Bye.